Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you back to another episode of Lengthening Live, episode 18. And we are here with Team LimbplastX from Las Vegas, Nevada. Today I'm joined by Mike, the PT Russell, and later on in the segment, we're going to have Dr. Debiparshad join us as well. Mike, welcome to the show.
Hey, thanks, Vic. Thanks for having me on, man. This is great. I'm excited.
Absolutely, man. I mean, this is probably one of the top promoted shows that I had on. I took a few weeks sabbatical there, but we're going to kick it off big. We have you, an expert physical therapy and rehab expert. So we're going to go ahead and answer some questions that were submitted from patients who were asking about physical therapy and rehab. So we're going to jump right into that. And then if we have any time after that, we're going to go into the live chat before Dr. D comes on. Sound good?
That'd be great.
Awesome. All right, Mike, we're going to kick it right off with question number one. The first one is, what are the top basic tasks that a patient needs to know how to do after limb lengthening surgery?
Right. Well, they obviously have to, you have to transfer. You got to get out of bed. You got to go to the bathroom, right? You got to be able to go home from the hospital. So probably the first of one of the many challenges that a lot of the patients encounter is getting into a car. Mm-hmm. So you discharge from the hospital, you're getting in, I don't know, if you're getting in an Uber or a Lyft, and you're trying to figure out, how do I even get in this thing? And it's difficult, right? So you have to be able to, and you're going to transfer from the wheelchair, you're going to stand with your walker, back into the car, get in the car, and then you got to do it in reverse. It just takes a little bit of getting used to, and you've talked about it a lot. You got to have the upper body strength. You're not pushing with your legs, unfortunately. They're just not ready for you. The quads are just not firing like they're supposed to. So it's you got to get to where you can transfer. Early on, the patients have a hard time rolling, right? Because the incisions, and I guess I kind of default to the femur lengthening a lot of the times, and I apologize. I don't mean to leave out the tibial kind of stuff, but it's the same thing, just a little bit different, right? You still got to be able to stand, you got to be able to transfer. Mm-hmm. And so it's kind of learning the little hacks to slide your legs in bed, slide back, because it's hard to lift your legs up as you're trying to lay down into bed and stuff like that. So when they get to me, the patients, we start working on that stuff right away. I feel bad. I don't mean to just stare at them and watch them try to lay down, but I'm trying to figure out, all right, what are you able to do? What are you capable of? And then we'll teach you how to do it.
Gotcha. So it's really important to get that movement immediately after surgery, learn how to transfer, because they are, especially for the patients who are going for cosmetic stature lengthening, they're getting it done bilaterally. So they're pretty much incapacitated from the waist down. Now, the next question that we have here is from a patient who is asking, when they start to do their stretching, which may start a few weeks after the surgery, the patient wants to know how hard is too hard when they start stretching. Like, how do they know that they're not going to damage the lengthening device? Would they be able to tell from a certain signal or cue, or would you instruct them as their physical therapist?
Hey, pain dictates everything. Okay. And you're not going to damage the device, especially early on. I think a lot of people get really, really nervous, especially now that the Precice 2.2 is out, the stride's not there. Everyone's extremely nervous about having a weight-bearing limitation on the nail. Right. For the most part, folks are within the weight limitations of the nail. Mm-hmm. They're not going to damage anything. We have to be a little bit more careful at 40 millimeters and beyond, right? Okay. As the nail's getting long, the bone's not fully consolidated, so you're just sitting on a nail. Mm-hmm. So that's where you got to be careful. But if you are in severe pain and the pain medication is not helping you, you've got to back out of the activity a little bit. Gotcha. So if the pain medication that's there to allow you to do your physical therapy. If you're taking pain medication and you're in severe pain from doing too much, I'd pull you back. Okay. And most of the time, folks, after they leave and go home, they're either doing too much or too little. And then we got to talk a little bit about what they're doing, and then we just make the modifications.
Gotcha. Yeah. So it's a really custom approach for each individual patient as the process continues. Very cool. Mike, the next question that we have here is from a patient who is asking, what are the key fundamentals of regaining a normal walking gait after the bone consolidation is sufficient enough? So after Dr. Debiparshad sees on the x-ray that the bone is starting to have the cortices, they can start to walk. Now the patient starts to have a little bit of a waddle walk. Some people call it the penguin walk, or whatever it is, zombie walk. What would it be, the muscles, the balance, or both? What type of things should they focus on to get their walk back normally so nobody notices?
So, two areas, right? Your hips and your foot and ankle control the knee. So, because you're lengthening, let's talk about femur. If you're lengthening in the femur, you're going to increase a joint angle from hip into knee. Tibia, you're going to go from knee down into foot and ankle.
Mhm.
So typically in the tibial lengthening, we're watching where the foot and ankle mechanics are. Were they doing their stretching like they were supposed to? You've got to be on a slant board like
Right.
a lot. You've got to get dorsiflexion or the ability for your toes to come back towards you.
Mhm.
It's huge. For the femur lengthening, folks, we're really focusing on the hip and early on hip mobility. So
Mhm.
rotating the hip in and out, and then making sure the strength. The hip muscles are really, really short, right? They're not very, very robust. The
Mhm.
glute muscles are nice and big, but you got their hip muscles on the side that aren't very big. So you just have to retrain them.
Okay.
What happens when we get that length and the penguin walk comes from when the feet are rotating out, right? So they
Mhm.
externally rotate and you walk like this. So
Yeah.
you have to strengthen the external rotators, okay?
Okay.
So it's the muscles on the hip that you're trying to get the strength back into, and they'll lose that slowly as they go. Here's the number one hack to get your walk back to a normal functioning. Walk backwards on a treadmill.
Wow.
Now, you have to be cleared. Make sure a therapist is watching you,
Mhm.
and be very, very, very careful because you don't want to fall and damage them. Under close supervision, reverse gait. You're going to work on your quads. You're going to develop proprioceptive
Mhm.
increases because you can't see where you're going. So your body has to depend on the joints to tell the brain, hey, this is where I'm at. So reverse treadmill walking is the number one hack to get people to lose the waddle.
Oh my gosh, that is like a golden nugget. Guys, did you hear that?
Take that. Please.
That
Yes.
is huge. I didn't even know that. That's so
Yes.
incredibly ingenious.
Yes.
Well, everybody knows about it now in the Limington community.
I love
Walking
it.
backward on the treadmill at a slight incline or flat? Do you want to keep it flat
Flat.
or flat?
And
Okay.
that's a very, very good kind of question there. And yes, because you have to bend the knee more to walk backwards up a hill. Okay.
Yeah.
So, but initially flat. If you
Okay.
feel like you can, if who you're with and someone's watching you and you want to try some incline, go ahead. But early on, a flat at 1 mile an hour or less.
Oh my gosh. I feel like I just like been ordained by like the great one here. That's so cool. Awesome tip there, Mike. Very, very cool. All right, guys, you heard that there. The next question here that we have is, what are the top rehab exercises that you would recommend to patients after surgery? So now we know that the patient is completely incapacitated. They're pretty much at the point where they can't weight bear, uh, and they're working with a physical therapist like yourself. But do all of the rehab exercises require assistance, or can they do some by themselves as well?
Everything I have them do, I have it to where they can do it on their own.
Okay.
And the patient is required to they're expected to do therapy on their own. So they
Okay.
can't just depend on me or another therapist or somebody else, watching them. So,
Hmm.
and it's all bed exercises, nothing's body weight yet. You can do bridging exercises and things of that nature because
Hmm.
you're not going to violate the weight bearing precautions for the nail or limitations. So it's a quad focused
Hmm.
and range of motion.
Okay.
Some passive for the range of motion, some active, but quad focused, getting the glutes involved after a couple weeks
Hmm.
and progressing from there. It's funny, it's a moving target, just like you said earlier. The rehab protocol is somewhat specific because as a patient's lengthening, they're incapacitated, they get
Hmm.
more mobile, and then the tension tightness as they get to that
Yes.
6, 7, 8 centimeter,
Yeah.
it really knocks them back. So it's like this little curve.
Right.
And so you got to be real careful with it. But yeah, bed exercises with bands,
Hmm.
straps, stretches, they can all do it very, very independently.
Okay, gotcha. That's really helpful. All right. All right, Mike, we have a few more questions that were submitted here, and then we're going to jump into the live chat. The next question here is, should patients schedule physical therapy with you before they go through with the surgery before limb lengthening surgery? If so, what's the best way that they can reach out to you? Should they just do it through the LimbplastX Institute, or should they reach out to you directly to schedule stuff? How does that work?
I'd love to do a consult with more folks getting ready to do this.
Okay.
Because so in the past, somebody who suffered an ACL rupture, for example, before they would go into surgery, orthopedic surgeons used to send them out to therapy so that they would have a better result post-surgery. The better you go in, typically the better result you'll come out.
Yeah.
So if you're flexible, if you have good muscle tone, if you're semi-active, you don't have to be a high-level athlete. But if you're used to exercising, you're going to have a much better outcome. So even just a consultation and, hey, here's what you should be doing. Here's suggested, and these are the musts.
Yeah.
So yes, absolutely. A consult with me would be fantastic.
Okay, gotcha. All right, guys, and basically we have Mike's link in the description below the video, and I'll even post it on the ticker at the very end of the live stream here. All right, Mike, we have let's see here. I thought I had one more question, but maybe that was it. No, this is my question. It's basically just this is my thing is saying, if you would like to say anything to patients who are considering limb lengthening, perhaps, is there a certain mindset or work ethic that they should have going into this procedure? Because I know I went through it. Multiple patients that I've spoken to in the last year and a half have gone through it, and it's a brutal procedure. There's a lot that goes into it, and there's a lot of rehab that not only stops, it doesn't really stop right at the end of the lengthening. You have to kind of keep doing it. So what type of words of wisdom do you want to impart on patients who are thinking about this?
Though I learned something as I started working with patients who undergo this procedure, and the thing I started to tell them all is, it's for some, not all, it's a cosmetic, right? Yeah. There's a desired outcome from this. Mm-hmm. And unlike breast augmentation, where you wake up and it's completed, you wake up and you go to work for the next 4 months.
I like that.
So if they remember that, early on, then they're gonna know that, look, I got to put some work into this over the long haul, right? Mm-hmm. It's just, yes, there's going to be pain. Yes, there's going to be some discomfort. Yeah. There's going to be good days and bad days. Yeah. So the mental toughness, just like you said, it's crucial. They've got to be ready for a little discomfort, right, and understand that, man, and I'm saying in the longest of terms, a year, you're gonna be up to 3.14 inches taller, mm-hmm, and walking around absolutely normal, doing everything you used to do.
Yep. That's awesome. That's awesome advice. And that's really good encouragement as well, because a lot of patients say, hey, am I going to be making it back to normal? And I can say that most of the patients who do what they're supposed to, listen to physical therapists like yourself, and, the doctor, everything works out in the end. It's like, it's made to kind of work. It's been standardized pretty well, but there is some hiccups along the way, but they got to work hard. And I love that you say the mindset's super important. All right, Mike. Well, that's all I have from the submitted questions. So we have a few more minutes before Dr. D joins. So you care to jump into the live chat with me? I'm going to pull up some questions here. So let's see here. Sure. All right, guys. Let's see what we got. All right. What was your previous what method did you use? Okay, here we go. Mike. All right. So from the Realm God, can you use neuropathy, nerve therapy, and relief cream to help relieve the pain during lengthening?
So during lengthening, and Dr. D would be the best person to answer this, but mm-hmm, what he typically does is he'll slow down the lengthening process. Okay. So if he's doing 1 millimeter per day in 3 parts, he'll slow that down or give you a couple days off. And typically that neuropathy or nerve type of pain will subside. Okay. Honestly, I'm not a big cream topical guy. There's a physiological change taking place, and there's some tensioning of nerves. Let the process take place, and it will resolve. It will resolve on its own. Okay. Usually.
All right. Yeah, Thorfinn, walk backwards on a treadmill. You heard it here first.
That's right. That's
Number one hack. I've never heard of that before. That's going to be spreading like wildfire this week. That's going to be big.
Just please don't fall. Please be careful. I don't want YouTube videos of fails in the gym of that. No, please don't.
Right, exactly. All right, let's see here. All right. So I guess you can answer this, Mike. You're pretty well versed in this. So do they teach you how to use the ERC remote before you go home, and how many times do you lengthen? Well, he said, yeah, go ahead. You can answer this.
Yeah, yeah, absolutely. In the office, pre-surgery and post-surgery, they're going over the ERC machine with you.
Hmm.
And then when I see you, if there's any questions, any concerns, any difficulties, yeah, we're bringing that thing out and making sure it's being used right.
Okay.
Dr. D's protocol is typically 0.33 millimeters per session, three
Mhm.
times a day.
That's what I did. Yeah. To
Okay.
get to that 1 millimeter. That's
Yep.
exactly what I did. Awesome. All right. Let's see here. All right. Yeah. Yeah, this is a good one, Mike. So Adam Silliman's asking basically, can I become a professional MMA fighter? Or let's just say getting back to martial arts, because I get this question a lot. People are worried about getting back to those high mobility and, physical activities that require a lot of nimbleness if they recover 100% from the surgery after doing the 3.15 inches.
Shoot, the first thing that comes to my mind is Conor McGregor, right?
Yeah.
He snapped his tibia during his last fight,
Hmm.
and he didn't have limb lengthening surgery.
Right.
So, is the question of refracture the
Mm.
question, or is it like, yeah, your functional ability, your muscle lengthening, your capability of mobility, your mobility capability?
Hmm.
Absolutely. I
Yeah,
don't think there is any limitation to this
that's
at
awesome.
all.
That's really cool. That's good news. All right. All right, so this is another question from Height Journey. He's another limb lengthening patient. Any recommended exercises for a limb lengthening patient in consolidation to improve his stepping gait for the stairs, up and down the stairs?
So there is a term called eccentric exercise. And
Mm,
there's in order to improve step down, or excuse me, step up, you work on step down.
mm,
And what you do is you stand on a step, and it can be whatever, 6, 7, 8 inches, 10 inches tall. And you're going to stand one leg on the step and one leg in front. And you're going to slowly lower to where the other foot, the heel is touching the ground. So you're trying to do, it's like a pistol squat.
mhm.
Okay. To slowly lower and then stand back up. Slowly lower and stand back up. That's a quad, it's an eccentric quad exercise. And once you get greater range of motion on the step down there, then you
Mhm.
turn around and you're going to start doing high step exercises,
Ah,
and
nice.
it'll be really, really good for you. But
All
start
right.
eccentrics first, and then work up to the isotonics.
The isotonics after that. Awesome, man. This is some really unique stuff I haven't even heard of before. This is cool. This is great talking to you. All
Yeah.
right, let's see here. Um, okay, so let's see. We already answered that one about the ERC. That's a surgeon question. All right. I think that
I'll
trying to
give
see if
one other hack for the folks that are going to start doing the lengthening process. When you get the procedure, you're in your home. If you would know this, if prior to stretching a muscle, if you were to stretching a cold muscle versus stretching a warm muscle or a warmed up muscle.
Mhm.
A warmed up muscle is always better.
Right.
So if you're going to take and lengthen, you're going to want to do pre-lengthening exercises or stretches. So
Ah,
don't, sometimes, and this is what happens on that third lengthening, people are in bed, they
mhm.
put the ERC machine on, lengthen and go to sleep and wake
Yeah.
up sore.
Yeah.
So try to budget your time to where you're going to put the ERC machine on, you're going to do some light exercises pre and post,
Mhm.
and then you can kind of do your go to bed procedure there. So
Nice.
a slight warm up before,
Yeah.
after will pay dividends in the end with
Yeah.
routine.
I remember I kinda, like, did that almost instinctually after finding out how tight I was when not warming up, and I was like, "You know
Yeah,
what? Let me do a little bit of, biking on the stationary bike," and then it helped
perfect.
tremendously.
Oh, that would be fantastic.
Yeah.
Absolutely. Yep, you're right.
That is great. Okay, this is a good one for you, Mike, and then, I think Dr. D will be on soon. Let's see here. People have reported atrophy during lengthening. Are there any residual effects of atrophy on ligaments, tendons, etc., or can all muscle and bone function be recovered? Okay.
That's a really good question.
Yeah.
And as far as I can see, because what's interesting, this isn't a new concept, right? Dr. D, he's funny. When I talk to him and we have discussions, and he's on trauma call, he does trauma call for the hospital. So
Mhm.
somebody falls and shatters their hip, he puts it back together and puts a rod through it, and away they go, right?
Right.
So there's not a lot of deleterious effects, right? There is initial atrophy from the lack of mobility, lack of blood flow, all those other factors combined. But up to 1 year prior to having that nail removed, I don't think there is any. You should be able to be as functional as you were prior to surgery, post-surgery, at that point of full consolidation, ready for nail to come out.
Awesome. Another really, really encouraging word, a little bit of words of advice there. Okay. Yeah. Okay. This is a good question because I've been getting, I kind of, in one of my last Limiting Live sessions, we talked about handheld massage guns. Now, these weren't out when I had my Lengthening years ago, but they're out now. And I wanted to get your take on this. So what's your thought about this for Lengthening, Mike?
So initially, I asked Dr. D about this. I said, will that percussion, right, that fast and that vibration go down and disrupt consolidating bone? And he said, no, it can't penetrate that deep. Okay. And I was like, cool. Then the other part of that is the gun is super aggressive. And they got a lot of ones now that they can range in from various speeds. So you got to put the flat head. There's different tools, right? Nothing pointed. You're not going to dig down on anything. It needs to be very, very surface level. And you can run that across the quads, hamstrings, calf. Tibias probably won't tolerate that very well at all, but the quad muscles can tolerate it very well. I sincerely, I have the patients that come out and see me, I get a massage stick.
Do you?
They massage stick at home.
You see, that's what
$10.
$10. Yeah, that's what I'm talking about. And you really believe in it, right?
It works fantastic. I use it for 4 months on the patient. Quads, hammies, calves, and they feel great with it.
See, guys, I told you I wasn't lying. You heard it from the expert himself. So there you go. Go buy your massage guns below.
Yeah.
That's awesome, Mike. Thanks so much for that. It's true though, because I noticed that I was using it a lot for my physical training, like working out and stuff, and I noticed that how much it keeps the muscle supple and pliable. And I was like, this might work really well for limb lengthening, and you just confirmed that. That's awesome.
Absolutely
awesome. All right, guys. So, do you have any more questions for Mike, the PT? He is an amazing physical therapist from Las Vegas. He works with the LimbplastX Institute, and he would be your physical therapist if you go there. Mike, if people want to reach out to you, I know you have a website below. Do you have any other forms of social media? How can they reach out to you, check out some of your stuff? Or
that's pretty easy. My email is mike@mikethept.com.
Okay.
That's pretty easy there. I'm on Instagram. I'm on Facebook. On Instagram, it's at Mike the PT. It's Mike space the space PT.com.
Okay.
And then I try to load up some videos on YouTube from time to time too.
Okay, cool. So after the live stream, if you can send me an email with all those links, I'll put them below the video, and I'll make sure that they're there so people can reach out to you directly.
I love it.
All right, let's see here. We have one more question in here, and then we have Dr. D. I'm going to bring him on. So let's bring him on now. I think he's on. Let's see. Is he there?
I can hear you guys. Can you hear me?
You can hear us. Okay. Yes, we can hear you, but we can't see you yet.
Yeah.
Let's see if we can get it in. That's okay. Take your time.
Yeah, no, I think I've got. Let me see. It says video. Front camera. Let me make sure.
Yeah, I know it can be tricky. I'll see if I can find a little button thing here.
It's the back camera.
There we go. We saw something. There he is. There's the man of the hour. How are you doing, Dr. D?
Good,
everybody, this is Dr. Kevin Debiparshad from the LimbplastX Institute in Las Vegas, Nevada. He is an amazing surgeon, and he is here to answer your questions live. Dr. D, how are you doing today?
Good. It's been a busy day, so I just I'm not sure how long I can stay either because I've got a couple more things to tend to, but I'll try to get through a few questions here with you.
Awesome, man. We really appreciate it. Well, we're going to get right into it. So there were some patients who submitted some questions for you because I promoted this episode. So we're going to hop right into it. And then if you have a few minutes, we'll take some from the live chat. But let's get right into it. All right, Dr. D. So the first question that a patient had, and it was basically about the Precice 2 nail. It's a popular device of, for patients who are going through lengthening. However, it's not fully weight bearing. Do you have any type of protocols that can help patients ambulate or walk when, or weight bear a percentage of their weight while they're lengthening, that you can talk about?
With Precise 2.2, and just like as an update, so Precise 2.2 about 2 weeks ago, I think now, has been released from product hold. So what some people don't know or may know is that it wasn't on product hold like Stride. So they were both on product hold. So we're using the amount of volume of Precise implants that we had in the field to actually perform most of the surgeries. And that was mostly being conducted at some of the high volume sites. So other potential sites and even other places outside the U.S. were not using Precice at all, actually. There was quite a few months that it was probably very difficult to even get your hands on a set of Precise 2.2 nails. Luckily, we had a fair amount of inventory here in Las Vegas, so we were able to still carry on with cases, as well as certain other places around the States. And probably that's mostly it. I don't think a lot of other places were doing too many of them. So that has been off product hold now. So we're now able to use the Precise 2.2 titanium nail.
Nice.
So that's good news. So that makes it a little easier so that everyone can kind of continue to do them both for deformity practices, pediatric practices, cosmetic practices, whatever the indication may be. So that makes the inventory a little more distributed throughout here, as well as it was released in Europe as well. So there was a time where Precice was taken off the market, and I'm not sure if I'm recovering information that you already know, but
some of this is new. Yeah.
Yeah, so then, so I'm obviously a consultant for the company, so I do a lot of work with them, and I meet with the engineers fairly regularly to discuss, product design and, improvements on the devices, as well as, some ongoing issues that we're having and just dealing with various regulatory boards on getting approvals. In Europe, and then hence following suit with other countries, you will see that Precice will kind of come back to the market. So they will be able to use that titanium implant once again. That's Precise 2.2. Obviously, Stride is still off the market. Not able to use the Stride implant, which is our stainless steel implant. However, that's our next kind of mission in life, is to try to see if we can get a more weight-bearing implant. So there's some ideas about, a Precise 3.0.
Wow.
Which would be a titanium implant. However, when discussing with the engineers, I think it will be difficult to reproduce it to be exactly like Stride in some ways, where it would be fully weight bearing. It could be augmented where there's more weight bearing, but I think it is a pressing design issue to make it fully weight bearing if it's fully titanium.
Yeah.
But it's one of the ideas that we have in potentially looking at a Precise like 3.0 essentially, which would be an implant that affords more weight bearing, whether that's 100 pounds or whatever that would be, more weight. And maybe for some light patients that might be fully weight bearing, but for heavier patients it may not be, as well as concurrently working on some of the design changes for Stride to see if we can have it return with less of the corrosional changes, which I'm sure you're aware of, to see if that may be another avenue. So there's kind of two paths of looking at that.
Okay.
For now, we have Precise 2.2, and one of the ideas that we had, at least here, there's not much we can do during lengthening. During the lengthening phase, we really depend on the dynamization of the implant to be able to capture length and that sort of stuff. So we do have weight bearing capacity limitations on the device. And a new update from the company is that based on their release of the implant from product hold, that number is really trying to be strictly at 50 pounds.
50 pounds.
So I know clinically we say for the 12.5 nail that sometimes we can kind of push to 75, but really the company has reiterated that it should stay within 50 pounds. Also, they're working on the indication for quadrilateral lengthening. So part of the relaunch of the Precise 2.2, there is a limitation, two other limitations, in that no more than 2 nails should be used, meaning that if you use a third nail, which would be like a quadrilateral case, then there's no evidence, from the perspective of looking at, metal changes and that sort of stuff. It's kind of off label, I guess I would say. So it's not that you can't do it; it's just it's not fully recommended by the company.
Okay.
Right. Also, that also goes for pediatric patients, which is another sticking point, since most of the business that is done from new basic with this implant is for the pediatric population. But one of the other points is that for patients, this implant should be used in patients above the age of 18. and so not our pediatric patient population. However, both those two things, using more than 2 nails, so 3 and above, as well as the pediatric indication, are being worked on so that that will be lifted, hopefully, to allow that in pediatrics, which is primarily a lot of the volume for the company, as well as being able to use more than 3 or more than 2 implants, i.e. 3 implants and more, for patients who have quadrilateral lengthening or need lengthening of an upper extremity and lower extremity and that sort of stuff simultaneously. So those are some of the things that are still little points that are out there that may not be of relevance to your audience potentially, but
they didn't know that.
But yeah, there are actually very specific guidelines to the release of Precice 2.2. I think people kind of forget that Precice, the titanium version, was actually put on hold, and has been held actually up until I think the beginning of this month. When it was re-released, but there are some clauses to the re-release, and those are the clauses, meaning that there are limitations on using them, and if you are using them, the company would have to consider that to be somewhat of an off-label use until they kind of accumulate the data they need to then submit to the regulatory boards to then say, okay, look, we have the data for 4 nails in a patient, we have the data for the pediatric, we have the nail, all that additional data, in which case those clauses will be removed, which I think will essentially happen based on the preliminary data that we have seen so far.
Gotcha.
So that's this one update. As well as the other stuff that I mentioned, but potentially a more so weight-bearing implant that's made of titanium versus some correctional changes to the stainless steel version of the implant. Mm-hmm. So back to your first question, which is probably about 10 minutes, about what can we do for patients. So I do have quite a bit of patients that go through the lengthening procedure, and I have noticed that certainly as they go into consolidation, where I'm sometimes more worried about their weight bearing actually, because oftentimes in patients, and I was just talking to a patient before I walked into here who's almost done with his lengthening, and he's doing very well. He's at 75 or 76 millimeters right now. He's almost at the last bit for a femoral lengthening case, and he's a bilateral cosmetic case. I actually get more worried often in the consolidation phase because they tend to feel better. Yeah. So the patients tend to be like, oh, my pain's better, and like got great range of motion, I feel great, and you start to feel much better. So you might feel a little more confident and a little bit more, kind of like, hey, I can do this, I can walk, and that sort of stuff. And that's actually what I'm most worried about implant, something happening to the implant, because it's fully lengthened out, and that's actually when it's the most vulnerable. The telescopic component of that nail is fully lengthened out, and that's where you'll see some of that, the weakness at that junction of the female-male junction, which is a concern. So one of the things we've done, and we've started to do these in patients here, is actually remove the Precice implant early. So we have this accelerated weight-bearing program that has garnered some interest from some of our patients, and may even put it up on our website. And I've offered it to some patients, and some patients have moved forward with it. So what we do is once you get to the 80 millimeters and you've gotten your length, you really don't need the Precice implant. In fact, at that point, it's somewhat of a limitation because you can't weight bear on it. It only bears 50 pounds at maximum capacity. And, these nails can bend. And I've started to see a small amount of bending these nails, especially in heavier patients, especially if they're trying to do more mobilization. So you have to still be careful and be very, very accurate on not putting too much weight on these nails, which sometimes can be a hassle. I mean, consolidation can take quite a bit of time. I mean, it can take as long as lengthening, if not more. I mean, in a good case scenario, we're looking at 2 months and patients will be consolidated, but that's not always the case. I mean, I have patients that take 3.5 months, 4 months to consolidate before I feel comfortable with them actually walking on it. And that's a lot of time where they could be doing something else, like rehabbing, learning to walk, and mobilizing, perfecting their gait pattern, that sort of stuff. So I have offered some patients, especially if I see that they're slow bone makers, or even patients that are average bone makers, the ability to remove the implant at that phase. So what we do is let's say 80 days is up and you're done your lengthening, you go and you slip the implant out, you put a tiny external fixer to hold the femoral length, and then you slide a solid titanium rod in, which is a rod that you get in a trauma surgery, or if you broke your leg or something like that, like a straight femoral nail or a tibial nail, you then lock that into place and you allow them to weight bear that day.
Wow.
So it does cut down the weight-bearing phase to be a little bit less. We can also, in addition, while we're there, percutaneously bone graft the area. So we have some special techniques and a little device I kind of made to try to bone graft the regenerate so that it actually will consolidate faster as well. So it can accelerate the consolidation. So for some patients, I think the limitation, and I still have, many, dozens or maybe 50 or 60 patients that, emails all the time about, asking about stride and when it's going to come back, because their limitation is that amount of downtime.
Right.
I think personally for me, if I were to do this, that would be my biggest limitation, honestly. I think that the implant and the technology is pretty much the same, and gaining length and all that sort of stuff, but the inactivity and the inability of the patients, I think that frustrates people, and I think they get to the point where they're like, okay, I feel pretty good, and but I'm still waiting. I'm just waiting around and not doing very much. And I think that for some patients can be difficult for patients, especially depending on what they do. You might have a very important job. A lot of the guys we have here in the city right now, and probably have at least 20 or 25 patients right now in Vegas, but a lot of them are tech guys, and so
Right.
they're okay. So they're just sitting on their computer and they're working for a company, and they don't need to be at home. But we still have attorneys and physicians and other types of people who want to pursue this. So to try to limit that amount of downtime, we are looking at trying to convert them into this accelerated weight bearing program. So AWP is what we kind of coined it as, to at least guarantee at the 80-day mark, if they choose to do so. Now you may say, hey, you know what? I'm okay with waiting. I'll wait 2 months, I'll wait 2.5 months, I'll wait 3 months. It's fine. You know what I mean? And I can give you some insight to that, because I could probably say, hey, you're a really good bone maker. Or you're kind of a slow bone maker, so this might take, X amount of time. It's hard to tell sometimes. It's hard to gauge that when you're looking at the regenerate, because sometimes you might look at one x-ray and then the next x-ray, all of a sudden they've laid down so much bone and you're thinking, wow, that's really great. And there's other medical tricks as well. There's medications you can use, there's certain bisphosphonates, there's things like Forteo and that sort of stuff you can do. There's things like, pulse ultrasound and, different techniques, which I'm sure you may be aware of, that can help with bone formation. So those can help as well to accelerate the process. But even with those things, sometimes that process can be long, that consolidation phase, and it can sometimes much longer than the lengthening phase, especially in tibial lengthening, that sort of stuff. So this is one avenue, at least, to kind of accelerate that program. It doesn't make it as good as stride,
Right.
But it does cut down it by at least 50% in my mind, if not more, because at 80 days, once you're done lengthening, and if you get the full amount, now if you get less, let's say you go for 70, 65, whatever you plan to go for, at that time point, within 24 to 40 hours, we can convert you to a full titanium nail that is not a Precice nail, obviously, and get you to be fully weight bearing immediately on that implant.
That is amazing.
So then, at least, you probably will have some soreness, that sort of stuff. Now, there are some downsides to it in some ways. One, it's another surgery, so that's a downside. There are other things, as I'm actually taking out the Precice, which you have to do anyways, ultimately. So you're just doing it earlier, but I am replacing it with another device.
Right.
However, that device, by the FDA regulations, is a permanent device, so you could theoretically leave the nail in forever if you like.
Okay.
If you don't like the concept of having it in there, then 1 year, 2 years, 3 years, 10 years, you can actually remove that at some later point as well. But it actually is still considered to be a permanent device. It's just like any femur fracture that you would have treated. Most of the time, we don't remove the intramedullary rod in those patients unless there's some reason to do so. So there's just pluses and minuses when looking at it, but at least it gives patients, I think, more of a certainty that there is something else that's out there. That if they had a hard deadline of hey, I got to be doing walk-in by 4 months, or I got to be doing this by this amount of time, it does give them a bit more security that they have an option to really be fully weight bearing and practice their gait pattern, practice their perfection walking, maybe do some more endurance strengthening during that time while they're consolidating, kind of like how stride was in some ways, to kind of reproduce that in some ways, and allow them to do a lot more, so that really by 6 months or 7 months after doing this, they might be able to be like a stride patient in some ways, where they're much more functional.
Right.
You know what I mean? Go ahead.
Yeah, I just have two questions about that. So, you said that they're going to put the external fixator. So it's almost like a lengthening over nail method, but without the nail lengthening. But would the external fixator come off once the?
You never see the external fixator. I put that on for the 20 minutes that it takes me to take the nail out. And put the,
okay, gotcha.
So
Okay,
you don't see it. And I try to use some of the old incisions, so I don't create any incisions.
So that's small. Okay, and then you said it's an extra surgery. I know patients are going to ask me this, so I just might as well ask while you're here. Do you have it's extra fees, but do you know how much? Do you have the quoted amount for that?
Yeah, that's a good question. I've been working on that number with the hospital a little bit. So it really depends. I mean, I think there'll be some additional costs. So don't forget, there is a cost to removal of the implant, and depending on which center that, I don't know, it ranges between, I think we charge something like $14,000 for that, and some places maybe a little bit more than that. I'm trying to keep the cost quite low, meaning that, and even for some patients, like I have one I'm doing on Monday that is exactly this, and some of his insurance actually covers some of the implant costs, so
Nice.
which is kind of nice. I don't think we'll always have that, but I mean, it is nice because it lessens the burden on the patient. My whole concept of doing this is really not to put more burden. I know there's a lot of financial burden with these types of procedures, and I get that a lot from patients. Is to try to keep the cost down. I think if we can keep it around that $20,000 mark, and consider that you're taking out the nail, which is going to cost you something anyways, and be able to replace it with a fully weight-bearing nail.
Yeah.
I think that offsets the price of Stride versus Precice. That was my kind of idea. In some ways, where I think Stride is, at least $8,000 to $10,000 more expensive of an implant in some ways, depending on the rate that you get. And if I can keep it to like only that much more, but include obviously the removal cost, that would be kind of what I would sort of would think for that. So I think I'm trying to think of it personally. Like if I was to do this and walk through this path, and I do so with so many patients, I know I could handle most of the components of the procedure, being like the pain and this and discomfort, and even the lengthy therapy involved with it. But I think the thing that would drive me, like be the most difficult about it, would be the inability to just get up and do what I want to do.
Oh, right.
And I think patients have echoed that to me as well. And I rack my brain thinking, well, how can we make this somewhat better for the patient, and how can we at least decrease that time? And I think it certainly sounds more palatable if you can say, well, look, I can at least guarantee it about 80 days. At the very least, I can make you fully weight bearing. I won't let you run because I don't think you're enough and that sort of stuff. I won't let you do like weights and that kind of stuff. But at least during that phase, you're a lot more active than a typical Precice 2.2 patient. That actually, I'm usually like telling them, oh, don't do too much. Like, be really careful. I want you to use the walker or use your forearm crutches or whatever you plan to use during that phase, because actually that's when I'm the most worried. And I think probably a lot of other surgeons would probably echo that as well, that they probably are the most concerned during that consolidation phase, because patients generally tend to feel better, but it's actually when the nail is actually its weakest.
I see.
Nail is fully lengthened out, so especially that male-female junction, which is the point of failure.
Right.
So, I think it's an avenue. In looking at my own patient population, and we still have a fairly large volume that are doing the Precice 2.2. Like, I've mentioned to a lot of patients. A lot of them seem very interested in it. I think I saw about 5 or 6 patients today that are going through the procedure who are at different phases, and maybe like 2 or 3 of them were like, one of them was like ready to sign up for it, and she's like, yeah, I'm going to go ahead and do this. I'm like, I definitely want to do this, just because they don't want to wait that amount of time, even though there's the thought of further surgery. But even for some patients, they don't even mind maybe keeping in the permanent implant, and they have the luxury of looking at it down the road. Also, given that it is a permanent implant that most surgeons use, it's not a specialized piece of equipment like the Precice or Stride that few surgeons have, the ability to do or feel comfortable with removals and the issues with them. I think any surgeon would probably feel relatively comfortable in removing a standard intramedullary rod that's made out of titanium. It can get a little trickier with these Precice and Stride implants, just because things happen, like they separate, and so you want to. They can often be actually sometimes more difficult, in my opinion, to remove, especially as you leave them longer. They can be more difficult to take out, and I'm sure other surgeons probably say the same thing. The longer you leave these implants in, but sometimes the more difficult they are to actually remove, especially Stride.
Okay, gotcha. That's a really cool thing. So you guys heard it here first at the LimbplastX Institute. They have the AWP, the Accelerated Weight Bearing Program. Is it live now, or are people able to kind of do this as of now?
Yeah, no, I've been offering it to patients. We haven't loaded up on our website and stuff. We probably will add it to our website and give it like a variable cost breakdown of what it would cost. And that would be dependent on the patient. I think for a lot of my foreign patients who are not from the United States, unfortunately, it probably have to be a cash value of some sort. But I'm trying to keep that value in the $22,000 range, so that it really is overall only about $8,000 more than
the Stride.
Well, actually, no, more than Precice.
Oh, right, yeah.
Than the total thing, which actually kind of pushes you close to what Stride actually was.
Right.
So and more, it's just because I think it's actually for me and the patient in some ways. I mean, in some ways I feel like, oh, if I put a long nail in there, I won't worry as much because I won't worry the patient's doing too much, and then I'm going to come back and see a little bend in the nail, in the Precice nail. So, in some ways it's for me because I know that at least if I have a fully, titanium implant in there, or it can even be a stainless steel implant, really, depending on the company you use. In there, I know that it'll afford them more strength overall, and I won't be less worried if they decide to leave Las Vegas or go somewhere else and be out of here. That I won't have to worry as much because they have a much stronger implant in there that can fully take their weight. So we're offering it to patients, and it's not it's there if they need it, it's there if they don't need it really. So and they can decide on day 80 really. So they could say, hey, how's my bone formation? I'll say, well, it's either average or below average, or you're really good at bone making. I probably wouldn't invest in this because I think you'll consolidate it. There's those rare patients who like consolidate in like 4 to 6 weeks, you know what I mean? These crazy bone makers, and the whole time you're actually worried that they're going to pre-consolidate.
Yeah.
And then getting to the end, and you think, okay, you're good because you're going to probably consolidate really soon because you're making a lot of bone. So there's those patients who just make a lot of bone as they're kind of lengthening, and that they're not going to have an issue with it. But yeah, no, it's available now. You can reach out to the office, even if patients who've had Precice lengthening in other facilities. If that's something that attracts them, it's an option for them as well.
Yeah, that's huge.
It's easier to take out the Precice as well during this phase because there's really not too much bone formation. There's no bony overgrowth of this phase. It's actually much simpler to take out the Precice. There's also less intrinsic damage to the Precice, meaning that I have seen Precice and Stride separate while I'm trying to take it out a year or two later. Right? They can break and they can change, and the distal screws can break, the proximal screws can break. Certainly with the earlier versions of Precice, we saw that a lot more often. It was almost like it's going to happen. Like the femur are going to separate, and you have to be clever in figuring out how to get these pieces of the implant out.
Right.
So in some ways it makes that process a little easier, a little bit more lengthy because you get attach an temporary external fixator and then replace the rod. But at that phase you can actually say you're done with the procedure in some ways. I mean, you still have to consolidate and heal, but you could actually not do anything else. You could keep those implants for the rest of your life.
Wow.
Because I generally will put a long intrusion that goes all the way down the femur, so it protects the entire femur. And at the same time, if you are a slow bone maker, I can augment the construct with putting a percutaneous bone graft in. So there's certain techniques that will be able to actually accelerate your bone healing at the same time. So it's all patient-centric. So I'm just trying to think, like, what are my patients telling me? What are they saying to me? And what can I do to maybe enhance the experience and make it go, easier for them and make it go better? And I think that's one of the biggest things. And I think it's one of the biggest things that patients are even reluctant to move forward with Precice. I think
that's what I've been hearing the most of right now. It's the weight bearing capacity and just like the time that they have to wait for the bone to heal, and that's huge.
That would, in looking at these patients and having just finished an era of Stride, I see it like before I didn't have Stride, so I was like, okay, this is just normal. But now that I've seen and gone through it, I look back and think, oh yeah, like it was, even for the surgeon, I feel like I also worried less. Like, you know what I mean? I have like more gray hair. I'm like stressed more about all these patients, not doing too much and doing this because I felt that it was a stronger construct to begin with. So I really didn't have to worry about anything because I knew that there was very little they could do to that implant to cause some kind of issue. It would be very unusual for that to happen. And I got to say, I don't think I've ever seen one of my Stride implants ever have actually any kind of problem with at least the mechanics of it. And last year, I think we did 118 cases.
Wow. Oh my gosh.
Stride, like in the world, I think. I don't think I saw any issue with the implant itself. The only issues really arose with these small corrosional changes that we saw afterwards. And in more recent days in removal, some of that translates into the removal in some ways too, because I do see some distal screws break, which make it a little more tricky to take out. I see proximal screws break as well, so that makes it a little trickier as well. So little things like that, which may have an impact on may or may not. I mean, we see these things anyways. Regardless if it's a stainless steel implant or a titanium implant, I do think that potentially, having the patients be weight bearing and possibly some of those corrosional changes may impact that. Why we see more of these distal screws change as well, like have these breakages and that kind of thing. So, So it's just one of those things that we keep hearing from patients, and I do think that it would be something that patients, just in presenting to my own patients, and we have quite a few that are undergoing the Precice 2.2 or in consolidation now, and even those who have already been in consolidation for some time, even they're interested in opting for this
Yeah.
option. Because they're probably tired of waiting around. And some of these patients have decided to stay here in Las Vegas, and a lot more have. Like I would say when I had steroid patients, primarily doing these cosmetic cases, very few patients stayed here. Very few. I would
Yeah.
say 5% of patients actually,
Wow.
maybe 10%. I don't know, will stay here. With Precice, certainly a lot more stay here because I think they feel a lot more comfortable staying here. And for the tech guys, it's cheaper to be here than Silicon Valley or San Francisco, where they're paying rent. So it tends to be a little bit cheaper with Seattle. It's just another approach to try to compensate for our lack of having stride.
Yeah.
But I do think that it will be a little bit of a game changer. I think patients, we can accelerate that process a little bit faster than them. I think I can get them to consolidate faster. I think I can get weight bearing by 80 days, which is a huge difference.
That's a huge difference, yeah.
Because and I'm sure you talk to a lot of patients, but I'm sure you probably hear day 200 still not walking. You know what I mean? Like I'm sure there are patients who are like that.
There are.
I mean, there have to be because I have a handful of them that that take they're just slow bone makers and so I think it's just another avenue. And then obviously there's some medical management of that and try to accelerate that. But even with those things, I still think you're looking at a 2-month window. During that time, you could have mastered walking by then.
Yeah. That's huge, man. Well, Dr. D, that's going to be huge news all throughout the limb lengthening community, and you guys heard it here first. So there's 2 more questions. I don't know if you have like about 5 or 7 minutes real quick.
Yeah.
Okay, cool. All right. So the next person is asking, I've noticed a shift in the amount of length that surgeons recommend that patients can get in terms of safe lengthening for cosmetic cases, I guess. He says, now I only hear doctors say, I wonder if he's basically saying that now surgeons are saying that you can probably push it to the max length of 8 centimeters, but in the past it was more so based on a percentage of the bone length. Is this because that their safety has actually increased, or there's more standardized, or is this more of a marketing stunt? That's what he's asking.
Got it. So certainly, well, I will say this. I mean, I think there's always we always want to make patients happy to some degree. So I think every surgeon will say, yes, we always want to do the best for our patients, and that patient has a particular desire, and that desire tends to be the full length, and we want our best to be able to give that, and we will try our best to do so. I will say that when looking at percentages, that's probably the best way to look at lengthening in some ways. Looking at the percentage of a bone that you can kind of lengthen, and depending on which data you look at, there's variable numbers out there in the data, right? I mean, there's some studies that look at 40% gains and 30% gains and 20% gains. So meaning that the length of the bone, whatever that length of the bone is, you can augment it by 20% or 25%. I think it would be fairly standard to look at a lot of studies and say the number of, I certainly think below 22, 25%, somewhere in that range. I think a lot of studies will probably show that anything below that number is probably relatively, I will say that they show a decreased rate of complications in those patients versus someone who may be above that number. And so what I'm talking about again, and depending on what study you look at, and it depends on the patients you're looking at in that study. So you can see some studies where it's 40% gain or these large amounts of gain relative to the bone itself, but you have to also look at the type of patient it is. Like an achondroplastic patient is not the same as a cosmetic patient who has normal anatomy. Right, they're completely different. Their soft tissues are potentially the reason some of those patients look that way too is because their soft tissues are kind of collapse themselves. Their pathologies are really in the bone itself, and they have short bones. So lengthening those bones, they often have a much better capacity to lengthen bone than the average patient who's built the way that they're built. But even if you look at those numbers and you look at the number 20% or 25%, if you look at the average length of a femur, I mean that's probably about 50 centimeters. The average height of a tibia, and I would probably say about 40 centimeters. 20% of that is within the realm of what Precice can sort of do. Meaning that I don't think it's inconceivable to consider that you can get 8 centimeters in a femur. I think it's more difficult to get that in the tibia despite that calculation, meaning that I think a number that's more reasonable is probably in the 6.5 centimeter range. But I do think that a large majority of our patients can achieve that, and that's not us trying to please the patient and get them, or I don't really care about any of that. I mean, my end goal is to really, and I think a lot of the surgeons in the field would they want to get the person who may to be in the safest way possible.
Right.
So, it doesn't matter how much length. If you have any error in that process, like, you know what I mean, like, that's going to be the issue, right? It's not going to be how much length. No one's going to care about the length at that point. But I do think that number is not an unreasonable number.
Okay.
Within even looking at the percentages, because if you look at an average femur, I mean, considering maybe 50 centimeters, you're augmenting that by 8 centimeters. That's actually under the 20% mark. In the tibia, it might be kind of pushing up into that level, but I think with tibias, I generally will tell patients about 6.5 centimeters. Now, if their soft tissues can tolerate, then I will allow them to go further. So like we just had a quadrilateral, and Mike might know the patient well because he's probably spent a lot of time with him. But he did lengthening, and I usually say 10, 11, depending on what your soft tissue is. But this patient, and he was a heavier guy too, so I didn't know how far you'd get, but he got to 12.5 with the quadrilateral case, which I thought was extremely impressive. I mean, that's 5 inches essentially all the way through with doing simultaneously. But he was very dedicated. He came to therapy every day. He got extra sessions. He pushed it. He did really well. He ended up he still wanted a little more, but I think he reasoned that he got pretty far and his soft tissues were getting just getting a little tight at that point. He decided to quit, which I think is still an extremely large number. I think it's a very admirable number to get to with the quadrilateral case, and he did very well. So I hope that answers the question to some degree.
Yeah, that absolutely does. Yeah, 100%.
So and I think it's case by case, and we don't mean to say that to like kind of get you to wherever we get you, and then go through the procedure, and then all of a sudden I say, oh, well, you're stopping here. So it really is to some degree. We can have some prediction in that, and I feel that femoral lengthening, it's more so achievable to achieve, maybe the full amount. I think it's more difficult. I also think that the more you space them out, if you're planning to do like femur tibia, I think it's also more easy to achieve the full amounts in each segment, because a lot of those soft tissues will be like doubly stretched, and a lot of those structures will be doubly stretched as you're doing quadrilateral lengthening. So that just some consideration through it. So, but
that's that's a perfect answer there. So one more question, then I'll let you kind of. I know you got to get going. Patients are really worried about that because a lot of patients are getting their stride nails removed, and they're wondering if there's this question has been popping up all throughout the chat when you were coming on. They were saying, is there a method to stress test or measure bone quality before nail removal to avoid bone collapse after nail removal? That's what they've been asking. And
I mean, generally we'll look at the, obviously we're taking x-rays to look at the cortical, density of the regenerate that is healed. So we kind of look at it like 4 walls to a bone. And we generally want to see that these, 4 cortices are fairly solidly healed. If we have any reluctance, there's not really any other way to know that. You can do a CT scan to look at it more closely. And I've done that rarely. I've done that in patients where I feel that, let me look at this a little bit closer because I'm a little skeptical about one of these cortices and I want to see the intensity, and that will give us better cross-sectional imaging through the actual bone to be able to look at different areas if you have a particular area that you're concerned about. And if I am concerned, I mean, and it's let's say a stride case or something like that, then, there is the option of doing something like I said before, where you can, always replace it and re-stimulate the bone by another device. If we're concerned about that in a particular patient. Other things you can do if you think that the bone may not be up to par, like we talked about before, there are some other treatments we do, like medical treatments, where I think most, if not a fair amount of like limb surgeons probably will use, which will be like medical management, things like bisphosphonates that we can give IV, which can help with decreasing bone resorption, which can help formation. There's some good data for that published in the literature, as well as either newer drugs like recombinant parathyroid hormone like Forteo, and there's some newer versions of that as well that some patients can use to try and enhance that. Some of those can be kind of pricey, so it just really depends on how we're sort of doing it. Particularly the Forteo can be a little bit pricier, but those are the things you can do if you want to delay the removal of the implant itself to make sure that you feel very comfortable that bone is solidified enough.
Awesome.
But usually we can tell if the cortices look fairly good on x-rays. It's generally reasonable to be able to tell that. If you have any concern and you really are worried about taking out the implant for whatever reason, like you feel like this is a stride implant, I really want to get it out because of whatever indication or some bony changes, you can always back it up with a straight implant, which is fairly straightforward to put in. It really doesn't require very much more time.
Okay.
And that process alone can help to stimulate the bone. I would say I haven't really had to do that, but it's a possibility.
Okay, awesome. And now I know you, last question here. I know you don't just deal with cosmetic cases, but you deal with all kinds of orthopedic conditions, including limb length discrepancies. This patient, Amaya, she has asked the question, if a discrepancy patient protocol calls for non-weight bearing during distraction and consolidation, how can you judge when both legs are finally equal in length upon standing and walking? So I guess when you know that the bones, are you just doing it by x-ray, or do you take like a gait analysis? How do you do that assessment?
So I do it by X-ray.
Okay.
So I'll do like a EL X-ray type thing, and I'll measure the bone based on that. So I can tell based on pelvic obliquity.
Okay.
I can just see that. You can get an EL study if you want as well, which will show you even a more centralized view because that's from like head to toe. But even an EL X-ray, so I'll be able to tell you exactly from from pelvis to tibia what that full length is. You can include foot height, so you can get a good idea of it based on X-ray. In fact, physical exam is often misleading in some ways, depending on something's tight or this or that. So I generally rely on imaging to be able to tell what the final limb length is, because I think it's far more accurate. And even the therapist, they may feel, I'm sure Mike can echo that, but you get patients who are like limb lengthening patients who, like a therapist or a chiropractor, not to say anything bad. I mean, they're just, they may feel something, you know what I mean? And that's fine. That's okay. They may feel that, hey, I think you're off by this or this. Get a lot from chiropractors, more so than probably therapists, but, and they come see you and then you do these imaging studies and you measure them and you're like, no, you're pretty much pretty accurate. I mean, and also consider that, looking at some of the osteology studies, like probably the average I think was zero point 0.4 in one study, 0.4 centimeters to be off between discrepancies between legs. So consider that there is a variability in patients, right? Where, not every person has even legs. In fact, when I even see patients from a cosmetic perspective, it's probably more likely than not that they don't have perfect symmetry.
Wow.
So,
That's really cool.
just consider that, yeah. And most, when you look at most studies looking at that, you can see that that tends to be true and hold true. I think the average is probably somewhere around the 0.4 centimeter mark. So.
Okay, very cool. Well, I'm gonna. I know you got to get going, Dr. D. So, is there anything you want to say to any patients who are considering limb lengthening with you at the LimbplastX Institute? And then I know Mike, you want to hang around for a few minutes and answer more questions, or do you guys both got to go? Okay, yeah. So good, Dr. D.
I'll defer to Mike to all the questions. No, Mike's very sweet, so all the patients love him. So no, I mean, other than that, I mean, we've got some good, I guess, news on the Precice 2.2 front, so that's positive news. So I'm excited about that because we get replenished inventory overall. We're still working on some other techniques on how to, not techniques, but implant designs, at least on trying to get a more weight bearing capacity type nail. So that's hopefully down the line, but I do still think it's going to be certainly into next, not 2022, but in 2023. I think it's still going to be a long time. I do think this like advanced weight bearing protocol is a nice in between. It's not perfection, but I think that to some degree it could be a game changer to some degree. I think we can certainly augment bone healing to accelerate the regenerate formation once you've kind of fixed your length and you've accomplished that length, and that can be timed whatever period during consolidation period you like. I would probably recommend sooner in some ways because then you get the advantage of weight bearing sooner and practice your walking and that sort of stuff. I do think that overall, from a rehabilitation perspective, patients will probably progress sooner and faster, meaning that 6 to 7 months after this procedure they'll be kind of more so normalized versus the Precice 2.2 patient, which I think they have to go through the lengthening, go through the full consolidation period, which might take them into 6 months, 7 months if they do the full amount of length. Then they start to walk and start to get normalized, and they're starting to look at 9 months or 10 months before they kind of look more sort of normalized. So I think it's certainly a way to improve the rehabilitation component of it, and I think that we'll probably see that be true. I think patients will probably be able to progress and do a lot more and return back to more activities faster. I think we'll be able to get the regenerative to heal a little bit faster as well. So I think there's some advantages to it, but not a necessity. You can do it the old-fashioned as well. I mean, if you want to just wait and hang out, then I think that's perfectly reasonable as well. And you have that judgment call, I think, as you get to that stage of what you want to do. So, but yeah, no, I mean, we're here still plugging along. I think we've got 12 cases this month in December. So it's a pretty busy time for us. We still be one of the higher volume centers. That's I think just the cosmetic cases. I think we still have I do lots of other surgeries. I think lots of 4 weeks.
Right.
Before I went on vacation, I think I did 85 surgeries,
85
over 4 weeks or something. So we're still relatively busy. We're working on some more data as well. So I think we'll recruit a couple of med student slaves to come help us a little bit, and a couple more hopefully to maybe get some more data published on looking at our results from Stride as well as Precice. And now there's some other fundamental questions I think patients often ask, potentially around things like the psychiatry behind it and the psychology behind it to some extent. I mean, there's some I think important questions that we try to answer with some of the data we collected prospectively in some of our patients, and we have quite a volume, so we're able to try to at least answer some of these questions and get an idea of what types of patients do this and for what reasons, that kind of thing. But I think all of that is very interesting data. I mean, I think it's very fascinating. And, it's a learning process as well. I mean, we're constantly learning more and more, I think, as we do this and as we kind of push the envelope in these types of things. And even looking at advanced weight-bearing protocols, I mean, that sort of stuff. I mean, that's even another component to it where, it's just it's just something new that's kind of in what we're offering to patients, just to make the experience a little bit better for them. So, and we're constantly expanding as well. Mike's, building stuff over there, and he's been busy building and growing, and we're also growing. We're looking at getting a bigger center that'll be a little bit. It'll be about 4 times larger than our current office, and we'll we have in-house therapy. I think a lot of patients ask that as well, but we do have in-house therapy with Mike.
Oh, you do?
Yeah,
nice.
we do. So we do offer in-house therapy, so you don't have to go anywhere. It's right here with us. But we'll be expanding on that and making that larger.
That's very cool.
Building. It probably will take a good year to be built because they haven't. I think they're just breaking ground on it. But we'll post some stuff on our social media and that kind of stuff to show the progress. Okay. That'll be kind of cool to kind of show the process of it growing. And then hopefully by sometime in early 2023 that, we'll have expanded into our newer location and, we'll be able to offer patients a little bit more. We'll be right after 215, so relatively close to the airport and pretty central overall to Las Vegas. And nice. So, those are some of the things that are on the horizon for us. And we're constantly looking at making patient experience better and the things that they kind of tell us about and give us feedback about. We've looked at it, and maybe, Victor, you can do some of the legwork on this and find out about, maybe having an internal shuttle service. We thought that might be something that might be helpful. A lot of our patients felt that, when they come to see Mike for therapy every day and come see me for their appointments, they'd be like, oh man, I wish I just, they call Uber or Lyft or, maybe they use the hotel shuttle, but sometimes it's not as reliable. So we did actually have a driver for a little while. We're looking at maybe seeing how we can streamline that a little bit better to make that something we can offer to our patients for either airport pickup or pickup from the airport or from around vicinity. So that way, and it would also streamline our schedule, both Mike and I, because we know that they'll show up on time. We're not going to come and see Mike on time because we got someone running over to grab them.
Right.
It's plus or minus. I think a lot of patients feel that's a good thing. Some of the patients who do stay at an Airbnb, for instance, and take Uber, feel that the Uber pulls up and they see the walker and are like, "Okay, hold on, I'm not taking you." So I've seen that. I've had a few patients tell me that, and I thought that was surprising. And then you never know who you'll get. So I think that's one of the areas we can expand upon because we have so many people. Even today alone, I think we had 6 or 7 follow-ups. All these patients are going through the procedure, right? So it just kind of maybe makes it a little more streamlined for them, especially if you're flying in potentially and that sort of stuff. We've also offered clinics on weekends, so that's pretty routine.
Oh, wow.
So
that's huge.
Saturdays and Sundays usually. So we do a lot of video consults those days, which makes it a little easier for certain schedules. And I also see patients. So patients will often fly on Saturday or Sunday. I'll do a 5, 7, 8 patient clinic. Patients, and then I'll let them fly back the same day, depending on how far they live. Some in California drive up. So that's, or from Utah or whatever, they'll just drive down to see us. So we do offer that to kind of make and facilitate, obviously, the patient experience, because I know people might work during the week and it might be more difficult. So we do offer clinics on the weekends. Most Saturday and Sunday, we try and clump them together so I don't live here. we try to clump them together so I can kind of at least have one day off or so yeah, those are some of the things that we just try to do, make the patient experience a lot better.
Nice.
Those kind of things working on. So yeah, let me know about the shuttle thing. I mean, we're pretty serious about it.
Yeah, I'll ask around in the Limbplastix community and I'll make sure I get back to you. So that's awesome. Well, thanks so much for coming on, Dr. D. We really appreciate it. All right, everyone, that is Dr. Debiparshad from the LimbplastX Institute in Las Vegas. We'll have him back on in a couple months for an update.
Okay, thanks, guys.
All right, thanks, Dr. D. Bye. All right, we still have Mike though. Mike, you're going to stick around for a few minutes?
Yeah, I can hang around. Absolutely.
Okay. Cool. All right.
So D's awesome, isn't he, man?
He's great, man. Guys, I mean, he just talked about the accelerated weight bearing program. I was super interested in hearing about that.
Unbelievable.
Yeah,
that is so cool, and it's game changer, especially for this Precice 2.2 product.
100%, because now it's kind of like bridging the gap between what Precice and Stride offered. So, and then working with people like you to kind of make sure you're getting that walking gait down. So, all right, we have a lot of questions in the chat. I mean, it's ridiculous. People are blowing this up. So we're going to try to get through. What do you say, about 20 minutes, Mike? You got 20 minutes?
I got it. Yeah, okay. 20 minutes would be good.
All right, so I'm going to pop them on the screen here, and you'll be able to read them at the same time. So, all right, so I answered one. This one's saying, in bilateral cases, have you seen one side consolidating at different rates than the other? If so, what are some of the top reasons for this, since both sides are exposed to the same nutrition, weight bearing, etc.?
So, I mean, this would be another good question, like for Dr. D. He'd go into a nice, complex answer, right? Now, so when he does let's just talk about femur. So when he does a femoral fracture, he does the line straight through. Sometimes when he does the fracture on the femur to get the separation, it's oblique.
Okay.
So if you have an oblique fracture or oblique, perfect, incision, if you will, there's more surface area and the bone will heal faster around that. So on your 2-week follow-up, he'll do the X-ray and go, oh, there's an oblique fracture in place, and he'll monitor that a lot closer. With regards to everything else, bone reacts to the stresses that are placed on it. So, and sometimes our body, it's taking a lot of nutrition to create that reparative process. And I've seen it in other cases like total knee replacements, where one knee functions really, really well, and then the other one just doesn't. And there's just no rhyme or reason for it. We don't know. We don't know why exactly that is.
Gotcha.
But yes, an oblique fracture, something with more surface area, will consolidate faster one side versus another. Okay.
Very cool. All right. This person's asking about bed rest. So, as shown in NASA studies, caused reduction in BMD. I'm not sure what that stands for, but and other bone health markers. How long does it take to return bone turnover and BMD? Hey, Inman, can you clarify that question? I'm not exactly sure what that is, but we'll keep plugging along here.
And see if that study is gravity related or just bed bound or bed rest.
Oh, that's a good question. Yeah.
So we want to make sure of that.
Yeah, clarify on that one, Inman. Okay, so this one's asking about, can someone go through the surgery with a pirifomis syndrome? So you know well about this. Can you explain that?
Absolutely. You absolutely can. You'll probably develop a little bit of pirifomis syndrome after surgery, right? Sitting in a wheelchair or a chair or in bed a lot, putting some pressure down into that area there. So if there's a spinal complication, like, and then there's a herniation or a some other complication in the spine, let the surgeon know what is going on there so that they can determine it. But if it's just a piriformis tension tightness or a glute tension tightness, absolutely, we'll get that resolved with the exercises.
Nice. That's really encouraging. All right, let's see here. All right, good. We're going to scroll through some of these. Okay, we answered that one about. Okay, let's see here. How long does it truly take to strengthen the bone, tibia or femur, once the nail is removed after lengthening? So, like, this is after nail removal, Mike. How long? I know for me, I know my surgeons kind of said like about 3 to 6 weeks of no like high stress activity. What's your suggestion for patients, like when they can start to kind of pick up the sports again?
Perfect. I was just going to say, a doc kind of runs between 6 to 8 weeks, depending on what he sees on the X-ray. Yeah. So once that nail's out, and doc gives them the clear, you're going to phase right back into it. You're going to be sore once again, if you remember. Yeah. So the soreness, you don't really feel like being a high-level athlete all the time. So once the soreness subsides, that's about the time period that you're going to you're going to be feeling more like returning to the gym or returning to some level of activity. So 8 weeks, you start begin that process all over again.
Okay, gotcha. Perfect. All right, here. Let's see here. Okay. Oh, wrong. Here it is right here. I clicked on that one. What are some daily routines you recommend for patients they should do after limb lengthening surgery? So, well, the really good thing, guys, Mike actually has a lot of, he said he has a content on YouTube. So he's going to send me his YouTube link and so basically, I'm going to post those links to his social media below this video after we're all done, probably tonight or tomorrow. And you guys can check out some of his content and reach out to him and consult with him. And he can, work with you guys and get you some all that stuff. But it's going to be, I guess, individualized, right, Mike? You have to work with each patient.
Absolutely. And so Doc talking about, and it was nice. I'm glad I stayed on because we miss each other a lot. And so these things are changing, right? And so he just said consulted with Nuvasive. And there's instead of 75 pounds, it's 50 pounds.
Yeah.
The weight bearing on that nail. They don't recommend more than that. So,
right.
During Stride, we would have patients walk 1,000 steps a day, 2 weeks post-operative. Mm-hmm. And now it's down to like 300 steps.
Wow.
So we are cranking them back. Just like Doc said, we are trying to be real careful because like he said, what's happening is that full length, you stop lengthening, you're off the pain medication, your range of motion's coming back. And then what happens? They trip, they catch their toe, or their assist device slips. And then they do that crucial step, twist, and something like that happens. And then that's when the injury occurs. And he's right. I'm thinking of 2 right now that he's dealing with.
Yeah.
And that's, your heart goes out to them because they've endured this process, and then they got one more challenge ahead of them. So
yeah, wow, yeah, I know that's what he said. He says once you start to consolidate, you feel good, and all of a sudden you get real confident, and you trip and fall, and then you can get a fracture from that. Okay, let's see here. So somebody's asking about. Okay. Oh, here's a good one, Mike. Gaining weight. I actually did a video on this recently. Do you gain some weight if you use the Precice nail, and if so, how many pounds? I guess, yeah. I don't know if that's a really good question. I thought I read it differently, but if you want to answer it, you can. The Precice nail doesn't weigh that much, guys.
No, it's very minimal. What were you thinking? What was your?
I was thinking like after surgery, you're going to lose, like during surgery, you're going to lose some weight, but then you'll gain weight back. With your patients that you work with, how soon after surgery do you notice that they gain their body mass back to pre-op levels?
Yeah, and that's exactly what I was thinking where you went with it, right? Mm-hmm. Because we're noticing as their weight drops like significantly. So let's say, for example, a 145-pound individual comes in and gets the procedure done. Let's say they lose 15 to 20 pounds. That's a significant weight loss when they're trying to reform bone. Mm-hmm. And they're losing weight, like you have mentioned before, because of loss of appetite, caloric deficit. Mm-hmm. So because those things are happening, and so we're noticing, okay, as weight drops, their bone healing is going to take longer. So we're already seeing, okay, you've got 8 to 12 weeks for bone consolidation minimum, unless you can get your weight back up.
Right. That's awesome. Great answer. I love it. Okay, let's see here. Okay, we're going to skim through. We got about 10 minutes left. So I'm going to go ahead and pick a few questions here. Mike, we really appreciate you coming on, man. You give such unique answers that I haven't heard before in the industry. So this is really, really refreshing. Yeah, sure. All right. They're talking about scarring. We've answered those before. Oh, this is a good one. Zeno-san is asking, are there things that the PT, you, and Dr. D disagree on during the lengthening process? Do you butt heads at all?
No, honestly, never.
Wow.
And he's turned to me and goes, what do you suggest that they do? And we just kind of went through it real quick. And Dr. D's, he's incredible. He's very thorough in his explanation. So we rarely have a miscommunication where I'm trying to push somebody and Doc's like, oh, hey, pull it back just a little bit because he's seen the x-ray, right? He's seen what's going on inside. I only see the external. Gotcha. And so I rely on that heavily and say, hey, what did the x-ray show? What did Dr. D say? Okay, awesome. All right, now let's revamp your rehab.
Look at that, a 1-2 punch. You got a perfect team over there at the LimbplastX Institute. All right, here. Okay, so Mike, this question from Richard to you. He's asking, I do powerlifting. How long will I be out from heavy lifting if I get this procedure? I assume I can still lift heavy upper body wise quickly after the procedure?
Yeah, I mean, if Richard is a power lifter, man, you're gonna need to take some time. I mean,
Yeah.
I'm thinking post nail removal if you're gonna get the nail out. Now for upper body, it's funny. Everyone wants to just if someone's very very active, they're like, when can I start doing core exercises? When can I do this? Man, you don't feel good.
Yeah.
You're not. You just don't feel like hitting it hard.
No. Not
Right.
at all.
I mean, it takes some time. I mean, at least a month and a half, 2 months before you're like, yeah, I'd like to do some upper body stuff. And you can, do some, whatever it is you feel like doing, but powerlifting is going to be tough.
Yeah. Yeah.
Well, if you're going to lay down on a bench and you want to do a heavy bench, how much of it do you drive through your legs?
Yeah.
Your legs are on the floor and you're doing a big drive and you're pushing a heavy weight. Not in limb lengthening, you're not.
That's good advice. And I agree with you 100%. Right around that 6 to 8 week mark, I really did a lot of wheelchair workouts. I was with, light dumbbells or something like that. But really the first month, I kind of just sat there, did my lengthening and my rehab, but that's about it.
Yep.
Great,
you're right.
Great. All right here. Mike, Richard has a second follow-up for you, as in how old was your youngest patient? Okay. As in maybe they were asking.
Oh, maybe that.
He's saying, I wonder what was your youngest patient was, or like, how old was your youngest patient that you worked with?
Well, what's funny is Dr. D, I mean, this is indicated for pediatric use, right? So, but I would imagine there is something related to the growth plates and whether or not they're closed, whether doc can drill through them and put nails through them. He just did a corrective case on a young man. He was 16. So
16. Okay. That's awesome. All right. Oh yeah. That's so funny. Somebody just said 16. I don't know how they know that. Yeah. These people know everything. I swear they're minions. They figure things out.
They do. It's great.
Yeah, they do. All right. Let's see. Anything that's for Mike, the PT guys, that he can answer? Because a lot of these we've answered to get 8 centimeters on the femurs. Wow, I'm going to scroll through about halfway here. Okay. Here we go, Mike. And man, is the hip load and geometry altered after the muscles are stretched?
I think N-Man asked the NASA question too, right?
Yeah, you did.
This individual is going at it. This is great. Is the hip load geometry altered after the muscles are stretched? I don't know. I don't know. I don't know. I mean, there's going to be some angle changes, and just like Doc was saying, he on that radiography that he does from pretty much mid spine to the floor, and he can see the obliquities and see some of the changing. And yes, you're going to have the geometry, the physics of your lower extremities have changed slightly, and your body has to readapt. So, and what's hard about this is, from my field, everything, we're going into an exercise-based field, not so much massagey kind of stuff like that. It's more exercise-based, and we can't do a lot of that weight-bearing functional movement type of stuff with this. We have to wait till you're consolidated and move on from there. So it's tough.
Yeah, 100%. Okay, here, let's see. Okay, we got a couple more. Okay, so we answered that one, the youngest patient. It feels like they're repeating a little bit. I hope that this chat is, bone mineral density. Oh, BMD was bone mineral density.
Okay, that makes sense.
Yeah, that makes sense now. Okay, thanks for that, and man, we got that now. But yeah, okay, here we go. This is for Mike from DT. How fast can one return to peak athletic performance if you have full dedication in PT and you have a professional team of PTs and physios to help you recover faster? Is 10 months good to be back on the field?
So I had a fun conversation. It was actually on YouTube about this, and they were very, very adamant about being back to full athletic participation in less than a year.
Wow.
And here's the thing, you cannot speed up biology. So, and if you guys listen to Dr. D carefully, right? So there's a period of lengthening, 80 millimeters is 80 days. In a perfect world. There's not many people, former patients, current patients, or prospectives that are going to get done in 80 days.
Yeah.
So figure you're going to go longer than that, right? Give yourself a buffer. And then you got the consolidation. Doc just said 8 weeks, sometimes 80 days to consolidate. So I get what DT's trying to ask.
Yeah.
And I understand, but you don't know until this procedure happens. So what I would say, I mean, an ACL reconstruction, a professional American football player who tears his ACL does not return to sport for a year.
Yep.
Period. The end.
Yeah, exactly.
So I would tell DT 12 months, and then you got to kind of depends on what you're going to do with the nail that's inside you.
Right. Good advice there. This one's for you from Amaya. I'm just scrolling down here. It says, Dr. Russell, can you also touch on my question about interpreting what it feels like in limb lengthening from a PT perspective? So I guess like for the limb length discrepancy case, that was her question about once she finally gets balanced bones, what about the muscles of how they're going to feel? Like, how will she know that she's back to like, good balance?
Yeah. And as we're going through the exercises, we measure right versus left. So Doc, like he said, I'm looking for symmetry internally. I'm looking for externally, right?
Yeah.
So can you straight leg raise? Can you lift your leg up off a table 10 times without bending the knee? And then I'll measure the left side. Well, the left side's not doing it. Okay. Well, why is that? Is it a range of motion limitation or is it a strength limitation? And then we can assess that. So it's through trial and error where it's diagnostic therapeutic, right? We're doing the action or performing the exercise, noticing, well, this is less than this. So one more set on the weak side.
Okay. I love it. That's kind of what I did. All right. Let's see here. Yeah. Thorfinn saying he's never heard your tips before.
Sometimes it's a different eye. Like I met Dr. D 3-ish years ago.
Okay.
And started in on the stride when he's got his Limmplastic Institute going. And so it's kind of from standing outside, watching what was happening back east and then seeing how okay, well, this is my new adaptation. This is how I would adapt this. And what's funny is I'm trying to push people like normal post-operative patients would be. You progressively get better. But not in this case. You get somewhat better, and then it goes back, and so you have to adjust for that.
Right. Yep. That's really cool, and that's why you have such unique tips. And I think the whole limb lengthening community is going to be like talking about this lately. All right. So last 3 questions here, and then we're going to wrap it up. So Edgar Vega, would light aesthetic weightlifting be safe to do during lengthening process under the lengthening over nail method? Oh, you touched on this a little bit earlier.
Yeah, absolutely. And you're going to definitely participate in it. And I do external weights. Absolutely.
Oh, okay. Perfect.
Yeah, I do.
Okay.
I use them.
All right. And this is a really good question. We're going to take this as the last question, guys, and then we're going to wrap it up. So this one from Inman, there we go. We'll finish on him. Do more cushy beds, or I guess beds with more cushion, affect stretching? So like when you're doing your stretches at home by yourself, is that going to affect stretching, or should you have like a rigid or less cushy PT table, massage table?
Well, I'm disappointed because Inman was coming at us with bone mineral density research, and now he's talking about cushy beds. So I don't know. He's like, I'm asking them too hard. Let's go to softball, right?
Soften up a little bit. Yeah.
Yeah. So and I send folks that I send home with to do exercises with. So if you can imagine laying flat on your back with your knees bent, bridging or lifting your hands off the bed, doing that on a soft surface is very, very difficult to do.
Yeah.
So yes, a more firm surface. Now, one gentleman, he was interesting. He had his femurs done, came back and got his tibias done, but he was stride before and now Precice. And he was like, do I have to get on the floor, be able to get on the floor to do my exercises? And I said, I really wouldn't want you to do that because I don't want you to fall, right? Or I don't want a complication. And he just ordered a massage table.
Wow.
He put it up in his house and said, well, there's a firmer surface than a mattress, right, that you sleep on. And he would do his exercises there.
Yeah. And I think it's night and day, really. You can feel the difference of you can pivot better on the firmer surface. But when you're in your bed, it's just much harder unless you have a firm bed. But
true.
Awesome. Awesome, 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 guys. Well, that is a really jam-packed limb lengthening live session here. Mike, we want to thank you so much for coming on to share your experience and your, expertise on this, limb lengthening procedure. Do you want to say anything to patients? Well, you said it earlier, obviously, but like, is there anything that you want to kind of say to kind of wrap it up to close out the show?
Yeah, absolutely. Hey, your platform is fantastic. This is exactly what folks need, right? Because there's a lot that goes into this, and just like you said, these folks do the research. So rather than it just be a wild, crazy, Wild West, internet, you're at least honing it down, right? And you're not just getting one person's explanation. You're getting multiple. So people get a filter through that. So that's what's fantastic about this. And this is pretty cool. Sometimes people are very, very secretive, not in a negative way, but just they want to be very discreet about this procedure, and we're happy to provide that for you, anonymously, if you will, and just try to say like, hey, this is how you want to get you back to better and doing everything you were doing beforehand, and you can do that. So happy to be part of it. Thanks, Victor.
That's awesome. And guys, you can reach out to Mike the PT Russell. He has his link to his website below where you can consult with him privately, and he's gonna send me all his social media links. And I'm gonna post them below this video as well. And I'll put them in the community as well, so you guys can reach out to him. He's been a huge value to this community, and we're gonna have him back on in the future as well. So everybody say thanks to Mike. Pump in the chat, give him your love. There you go. Thorfinn said thanks so much, Mike the PT. Pro tip: walking backwards on the treadmill. That's awesome. So we're gonna close out the show, guys. I want to thank you for joining Limb Lengthening Live episode 18 with Dr. Mike the PT Russell and Dr. Debiparshad from the LimbplastX Institute. And until next time, this is Victor from Cyborg for Life, signing out. See you guys next time. Bye.